Well, I hope you guys had a good lunch, and because we need to start this session, we are a few minutes late. I'm Miklos Seintat from UCLA, sitting here with Shonak Majumdar from the Mayo Clinic. And this particular session will be on interventions for necrotizing pancreatitis. And the first speaker is Mark Besseling, and I assume this will be a Zoom talk.
Correct.
Let's see. All right.
I want to thank the organizers for inviting me to present on approaches to necrotizing pancreatitis. I have no disclosures. So I would like to address these 4 clinical issues in necrotizing pancreatitis. What is the indication for intervention? Should you do a catheter drainage or necrosectomy first if you decide on intervention? If you drain, should you place the drain EUS-guided, transgastric, or percutaneously? And what should be the timing of the first intervention? So first, the indication. So this is an example. Patient, day 25 of pancreatitis, clinically well on the ward. What intervention does this patient need? Well, no signs of infection. Patient was treated conservatively, and this is the same patient 6 months later. No intervention, no collection to be seen. This patient, however, 29 days out, is clinically unwell, has fevers, and you see here impacted gas bubbles as sign of infection. So this patient went on to have a necrosectomy. You see the peripancreatic fat necrosis and a part of the necrotic pancreas. So if you intervene, catheter drainage or a necrosectomy as a first step. Well, this was assessed in the PONTA trial, published more than 10 years ago already in the New England Journal of Medicine. And basically the PONTA trial showed us that a step-up approach, so first delaying intervention, then draining, and then if needed, debriding, decreases the incidence of new onset multi-organ failure from 40% to 12% when comparing to primary laparoscopy. So clearly an improvement by the step-up approach. And in this study, percutaneous catheter drainage was technically feasible in nearly all patients. And furthermore, catheter drainage percutaneously was the only intervention needed in 1/3 of patients in the step-up arm. So the step-up approach, clearly the way to go. So these are just 4 examples of patients who could be treated with only percutaneous catheter drainage. Here another collection with impacted gas. There's another patient, and also this patient with infection. These 4 were treated only with percutaneous catheter drainage, showing you that not always necrosectomy is indicated. So if you go for catheter drainage, should it be done EUS-guided or percutaneous? Well, this was actually assessed in the tension trial in the Lancet, published 3 years ago. And it showed that the endoscopic step-up approach has a similar rate of a primary endpoint, a composite of major complications and death, as compared to the surgical step-up approach. So EUS-guided drainage versus with EUS-guided necrosectomy compared to percutaneous drainage and minimally invasive surgical necrosectomy using this retroperitoneal drain, no difference in complications and death. However, the endoscopic step-up approach reduced the rate of pancreatic fistula from 32 to 5%. There is still a fistula, but it drains internally, which is better for the patient. And surprisingly, the endoscopic step-up approach reduced the hospital stay from 2 months to 1 month, potentially because in the surgical arm, repeatedly new drains were placed, whereas in the endoscopic arm, endoscopists more quickly moved to necrosectomy once the initial drainage did not lead to clinical improvement. And then finally, if you go in, what should be the timing of the first intervention? How long to wait? We did a survey published in HPB 5 years ago, asking about the diagnostic strategy and the timing of intervention ineffective necrotizing pancreatitis among international experts. And we also showed them several clinical cases. And about half of the experts said, well, I would not wait for the impact of antibiotics. I would drain with catheter drainage an infected collection immediately. Moreover, nearly 90% would drain an infected collection before the stage of walled-off necrosis. And then 2/3 want walled-off necrosis before they perform endoscopic drainage. So there's some controversy here. So this was assessed in the POINT trial, published a couple of weeks ago in the New England Journal of Medicine. So retrospective studies suggest that if we go in early, we drain in earlier, outcome may be better. So the hypothesis being that encapsulation walled off may be less important if you decide to intervene minimally invasive. And immediate catheter drainage so early on may prevent worsening of ongoing sepsis. This is the hypothesis. So in the POINT trial, we screened for patients with infected necrotizing pancreatitis who were randomized to immediate drainage within 24 hours after diagnosis of infection, or a postponed catheter drainage, where we try to wait until the stage of walled-off necrosis using antibiotics to do so. So patients either with gas on the CT, positive gram culture, or clinical suspicion, one or more of these three were included. Within the first 14 days, either gas or positive gram was required. After 14 days, clinical suspicion was also sufficient. Clearly, a catheter drainage had to be feasible. The patients who were more than 35 days out or who needed an emergency laparotomy were excluded from the study. So the comprehensive complication index was used as the primary endpoint, which combines all morbidity. So baseline 55 versus 49 patients were randomized, pretty comparable. ASA score also pretty comparable. 1 in 4 patients was admitted to ICU, again comparable. Organ failure, single, multiple, and SIRS comparable between the groups. Timing between onset of symptoms and drainage, 24 versus 29 days, and time between randomization and drainage, 1 and 9 days. So you see here, we succeeded in postponing with the first drainage for 8 days. The primary endpoint, comprehensive complication index, no benefit, actually a bit higher, but not statistically significant, no benefit for immediate drainage. Mortality also 11 versus 10%, no difference. New onset multiple organ failure, although this seems a bit less, this is not statistically significant. And also bleeding, fistula, pancreatic cutaneous fistula, no difference, no benefit of immediate drainage. Exocrine insufficiency, more than 1 in 3, low fecal elastase, endocrine insufficiency 1 in 5, no difference between the groups. Days in ICU, no difference, and actually surprisingly, there was almost 2-week longer hospital stay if you drained immediately. So potentially a longer hospital stay, just not significant if you drain immediately. So no benefit there. If you then look at the number of interventions, well, it will not come as a surprise that if you start draining earlier, in the end you'll drain more often. So median 4 drainage procedures in the immediate group versus only 1 in the postponed group, which is significant. Total number of drainage procedures, 2 versus 1. And total number of necrosectomies, 1 versus actually 0. So all these differences are statistically significant. Drainage was performed in 100% of the immediate group versus only 61% of the postponed group. So as you can see here, 39 required no drainage, was treated with only antibiotics. And necrosectomy, half of the patients here versus only 1 in 5 in the postponed group. So this could be seen as a benefit of postponed catheter drainage. So my take-home message for you as the first presentation of 4 in this series is that Postponing intervention in patients with infected necrotizing pancreatitis using antibiotics is probably a good thing to do, a way to go forward. It will lead to conservative treatment in nearly 4 out of 10 patients. No drain, no necrosectomy required. If you then decide to intervene, endoscopic catheter drainage should probably be the initial treatment. And if that's not feasible, it's always retroperitoneal percutaneous catheter drainage feasible. If after 1 or 2 or maybe 3 drainage procedures there is no improvement, move towards necrosectomy. Otherwise, you will have a postponed and prolonged period until full patient recovery, as we saw in the tension trial. That's it. I want to thank all the Dutch centers who participated in the study, and I want to thank you for your attention. Thank you very much.
Thank you, Professor Bezelnik. That was an outstanding talk. Our next speaker for this session is Dr. Surinder Rana. Dr. Rana is a professor of gastroenterology at PGI Chandigarh in India. His research interest is in pancreatic diseases and therapeutic endoscopy, and he'll be speaking on percutaneous interventions of necrotizing pancreatitis. This will be a virtual presentation as well.
Good afternoon, everyone. At the outset, I would like to thank APA for this kind invitation. Today, I'm going to speak on percutaneous interventions in acute necrotizing pancreatitis. We all know that 5 to 10% of patients with acute pancreatitis will develop necrotizing pancreatitis, and necrotizing pancreatitis, especially if infected, is associated with increased morbidity and mortality. Over the last few years, we have been witness to a paradigm shift in the management of these patients. The management has shifted from early surgery to delayed minimally invasive interventions. So if you look at the current management strategy of patients with pancreatic necrosis, it is minimally invasive. That means either we do an image-guided percutaneous drainage or an endoscopic transluminal drainage, and if required, a minimally invasive necrosectomy in the form of endoscopic necrosectomy or a ward. Another important component of this strategy is a delayed management, that you intervene as delayed as possible. Why is it so? Because we know that as the time passes by, the pancreatic necrosis tends to get more evolved. That means that it gets encapsulated, there is a well-formed wall, it tends to get well demarcated, and the amount of solid debris gradually decreases, thereby making intervention more easier and more successful. That's what we documented in a study where we serially studied these pancreatic necrotic collections with endoscopic ultrasound over a period of time, and found that these collections tend to get more mature, more liquefied with a period of time. However, this maturation process is little slower. It doesn't happen in days, but it happens over a period of weeks. And the liquefaction is again very, very slow as compared to the maturation process. And similar results have been obtained in a pointer study, which has been recently published in New England Journal, where it has been shown that the strategy of a delayed drainage is better in terms of requiring fewer interventions as compared to doing an immediate drainage of necrotic collections. Now, what are the percutaneous interventions which we can do in patients with acute necrotizing pancreatitis? We can do a simple catheter drainage. We can use multiple catheters and large bore catheters, and then one can resort to a lavage with using either a saline, hydrogen peroxide, or streptokinase. Then one can also do a sinus tract endoscopy and percutaneous endoscopic necrosectomy to remove the necrotic debris. And then finally, videoscope assisted retroperitoneal debridement through the sinus tract, which is also known as ward procedure. Now, what are the indications for percutaneous drainage in acute necrotizing pancreatitis? Whenever there is a clinical suspicion or there is a documented infected necrotic collection, whether it is an acute necrotic collection or a ward of necrosis needs to be drained. The drainage can be either percutaneous or endoscopic. Then sterile symptomatic necrotic collections are also to be drained. The symptoms can be in the form of severe pain, early satiety, GI obstruction or biliary obstruction. And similarly, patients who have a new onset organ failure after 2 weeks of onset of acute necrotizing pancreatitis, or if the organ failure persists beyond 2 weeks, when the suspicion of infection is higher, then these collections need to be drained because this drainage can reverse the organ failure. And similarly, abdominal compartment syndrome is an important indication for percutaneous drainage. It will help in resolution of increased intra-abdominal pressure as well as consequent organ failure in patients with necrotizing pancreatitis. Now, since we can do either a percutaneous or endoscopic drainage, how to choose amongst the two? Now, we need to understand the advantages and disadvantages of either. So I'm going to talk about the limitations of percutaneous drainage. One of the most important limitation is inability to drain the solid necrotic debris by the drainage catheters. So this solid necrotic debris, there are large chunks of necrotic material which are difficult to be drained by drainage catheters. And then there is increased risk of external pancreatic fistula formation. Studies have shown that with percutaneous drainage, there is increased need for re-intervention, and the percutaneous drainage obviously leads to discomfort to the patient. There is risk of accidental slippage, and then studies have again documented a prolonged hospital stay in patients who have undergone a percutaneous drainage as compared to endoscopic drainage. But what are the advantages? It's a quick and safe procedure that can be done at bedside, and this is especially helpful in critically ill patients. And then studies have shown that percutaneous drainage alone without any surgical necrosectomy is effective in about 1/3 of patients. And also importantly, this drainage can be done in week 2 to 4 of illness when the collections have not matured, there is not a well-formed wall. So in that situation, the endoscopic drainage is a little difficult and one can do easily a percutaneous drainage. Now, there have been 3 randomized studies which have compared percutaneous and endoscopic drainage, and all these studies have shown that endoscopic drainage is superior, especially in terms of complications. Then there have been 3 studies, including one by us, where it has been shown that the necrotic collections in week 3 to 4, when many of these collections would not have a mature wall, can be safely and effectively drained endoscopically. And also there is one retrospective comparative study from our center where we compared endoscopic versus percutaneous drainage in week 2 to 4 of illness. And again, we have shown that endoscopy is better than percutaneous drainage in terms of hospital stay, need for interventions, and need for rescue surgical necrosectomy. So hence, the current evidence suggests that endoscopic drainage is a preferred route for drainage of necrotic collections. So then what's the role of percutaneous drainage? So we have to understand that endoscopic drainage is not suitable or possible in all patients. Like critically ill patients who are not fit for an endoscopic drainage can undergo a bedside percutaneous drainage. And similarly, there are locations like paracolic gutters and route of mesentery where endoscopic drainage is not feasible, and the only drainage possible is percutaneous drainage. And similarly, emphysematous collections with a lot of air cannot be visualized on endoscopic ultrasound, and these patients will require a CT-guided percutaneous drainage. Just to give you some examples, these are the paracolic collections which cannot be drained endoscopically and will require a percutaneous drainage. And similarly, collections which extend into the route of mesentery cannot be drained endoscopically, and they can be easily drained percutaneously via pararenal route, and this can help in successful resolution of these necrotic collections at these unusual locations. And importantly, at our center, which is an aggressive endoscopic center for management of pancreatic fluid collections, still 40% of collections are drained via percutaneous route, and majority of these collections are the collections which require drainage in week 2 to 4 of illness, and these patients have an coexisting organ failure, especially lung illness, lung injury, which makes endoscopic drainage a little difficult. Now, what are the results of percutaneous drainage? There have been a number of retrospective and prospective studies which have shown almost similar results. 1/3 to half of collections will resolve with percutaneous drainage alone. The other half would require surgery, and the mortality has remained fairly constant between 15 to 25% in most of these studies. Can we predict the failure of percutaneous drainage? There have been studies which have looked at the predictors of failure of percutaneous drainage. The predictors of failure are pancreatic collections which have a lot of solid debris, presence of renal failure, presence of high Apache 2 score at the time of first intervention, and a polymicrobial infection. So all these are the factors which would predict a failure of percutaneous drainage. But most important is the morphology of the fluid collection. This is one of our paper where we looked at the morphology of the fluid collections and its impact on the outcome of endoscopic drainage. So here we found that if you have more solid debris then you will require more aggressive endoscopic options like DEN, and many of these patients would require a surgical necrosectomy. And the same analogy will probably fall true for percutaneous drainage also. Just showing an example, a large bore percutaneous drainage, no resolution. We did a percutaneous endoscopic necrosectomy and you find large chunks of solid necrotic debris, and it is virtually impossible to remove these large chunks of necrotic debris through these large bore catheters, however aggressive you may be, and these patients will probably require a necrosectomy to remove it. Now, do you need to do an EUS or MRI in all these patients to document the solid necrotic debris? The answer is no. This is one of our papers where we showed that a transabdominal ultrasound is as good as EUS or MRI to document the solid necrotic debris and quantify it. Now, if your percutaneous drainage fail, what are the non-surgical options? The logical things are increase the caliber of drainage catheters, as was done in this case. First, we put a 12 French, doesn't help. Increase to 20 French and the collection resolve. But this will not happen in all the patients. Like in this patient, we went up to 24 French, but it didn't help. And this patient actually required ward. You can see these two drainage catheters. So increasing the number of catheters or increasing the caliber of catheter may help in some patients, but not in all the patients. Again, as I've talked about, multiple drainage catheters sometimes may help, but in substantial number of patients, increasing the number of catheters or increasing the caliber of catheters may not work. What about irrigation? There have been a number of studies which have looked at saline irrigation, hydrogen peroxide irrigation, or streptokinase irrigation. And this is a recent RCT from our center where we compared streptokinase with hydrogen peroxide. Most of these studies have shown similar results. In this study, we found that streptokinase and hydrogen peroxide were comparable, but the complications were a little higher in hydrogen peroxide group as compared to streptokinase group. But broadly, the conclusion from all these studies is that this may work in about 1/3 to half of patients, but another half of patients will still require surgery despite doing an aggressive lavage. Another important option is percutaneous endoscopic necrosectomy, where through the drainage catheter site, you insert an endoscope and do an endoscopic necrosectomy as you do it for a transgastric or a transdural necrosectomy. So you take the endoscope over the guide wire into the necrotic collection, visualize the necrotic material and try to remove it. But again, it is important to understand that percutaneous endoscopic necrosectomy is different from transgastric necrosectomy because here the tract is quite long. It goes through the facial planes. So the dilatation is very painful. People have even tried putting large caliber, fully covered metallic stents to facilitate necrosectomy. But then in many of these patients, it still may not work. And these patients would probably require ward for successful outcome. Another important option for failed percutaneous drainage is a hybrid drainage where you combine it with an endoscopic drainage. So here in this patient, there is an emphysematous collection drained percutaneously and then followed by an endoscopic drainage with multiple plastic stents. One can even use a lumen opposing metallic stents for a hybrid drainage, and this can help in quicker resolution of these necrotic collections. But then despite all these aggressive measures, about 25 to 35% of patients will still require surgery, and these patients have to be sent to surgeon to undergo a ward procedure to remove the large chunks of solid necrotic debris, which cannot be removed by any of the interventions which I have just talked about. What about complications? Fortunately, the complications are not so common with percutaneous drainage. The commonly encountered complications are sepsis, hemorrhage, and a bowel or a pleural transgression. But majority of them, if they happen also, can be managed conservatively, and surgery is usually required very infrequently to manage these complications. This is one of our paper published last year where we looked at the outcome of percutaneous drainages in 350 patients of acute necrotic collections. Again, fortunately, the complications were not so common, and in majority of these patients, it could be managed conservatively. Like for example, here the catheter has gone into the descending colon, here the catheter has gone into the jejunum, here the catheter has again gone into the jejunum with a bilious drainage output. But in all these patients, it could be successfully managed by withdrawal of the catheter, insertion of narrow caliber catheters, gradual withdrawal, and there was no need of surgery. This is one of the patients who had a catheter into the ascending colon, and this patient required surgery because of worsening sepsis, and this patient unfortunately succumbed to the illness. Then another important complication of percutaneous drainage is external fistula formation. So this is necrotic collection drained percutaneously. Didn't resolve, you had to resort to ward, and then this patient developed an EPF. Fortunately, in this patient, we could bridge the disruption and place a bridging stent, but majority of these patients with external pancreatic fistula have disconnected duct, and disconnected duct usually requires either surgery or complex endoscopic and US guided interventions for successful resolution. So to conclude, this is the protocol which we follow for managing patients of necrotic collections at our center. One of the important components we look at is the amount of solid necrotic debris, because it is one of the important predictors of outcome of percutaneous drainage. If the debris is less, percutaneous drainage alone is effective. However, if there is increased amount of solid debris, then we should be prepared to do aggressive procedures, which could be either an hybrid endoscopic procedure, percutaneous endoscopic necrosectomy, or a ward procedure. So to conclude, we have learned that percutaneous drainage is a first step to control sepsis, and percutaneous drainage delays or even avoids necrosectomy. One should delay intervention as far as possible. However, ideal lavage strategy, the solution to use for lavage, the amount of fluid to be used for lavage, optimal initial catheter size or benefit of upsizing or inserting multiple percutaneous drainage is still not clear, and we need randomized studies to answer these questions. We also need to devise techniques to improve the outcome of percutaneous drainage alone, as the current strategies of lavage or percutaneous endoscopic necrosectomy are not very effective. And an important point to remember is that no single approach is optimal for all patients. One has to be multimodal and adaptable to an individual patient to have a successful outcome. Thank you so much for your patient hearing.
Thank you so much for this nice talk. The next lecture is on the endoscopic management of necrotizing pancreatitis, and is given by Guru Trikudanathan from the University of Minnesota.
Good afternoon, everybody. I'm Guru Trikudanathan, one of the associate professors from University of Minnesota. I shall be discussing endoscopic management. This is my agenda for today's talk. So endoscopic management of necrotizing pancreatitis essentially involves EUS or conventional endoscopic guided cyst enterostomy tract creation, and then placement of stents, be it plastic stents or lumen-opposing metal stents. Once the tract is mature, we advance the endoscope into the necrotic cavity and use all sorts of accessories like snares or baskets to perform direct endoscopic debridement. And we can also use necrolytic agents like hydrogen peroxide or streptokinase, and we repeat them as needed and until we see healthy granulation tissue. The clinical outcomes of endoscopic necrosectomy has been compared with a surgical necrosectomy, and at least by 3 randomized controlled trials. 2 of them were performed by the Dutch pancreatitis group led by Professor Besselink. And all 3 studies showed that there was no significant difference in mortality between the endoscopic step-up approach versus open necrosectomy. And additionally, endoscopic step-up approach was associated with a reduced risk for fistulae formation. And the MISA study, which was done by Varadarajulu and others from the Orlando Hospital, went one step ahead and showed that endoscopic step-up approach were more cost-effective, and the total costs were significantly lower with the endoscopic approach. So to summarize, endoscopic step-up approach is associated with reduced physiological stress, and there is reduced risk for new onset multi-organ failure and decrease in the hospital stay. Definitely, there is significantly reduced fistulae formation, reduced overall cost, with no significant difference in mortality. The next issue is regarding timing of endoscopic transluminal drainage. And all the current guidelines suggest or recommend for us to wait as long as 4 weeks until the necrotic collections are completely walled off and fully encapsulated. But very often, we have a subset of patients who are critically ill with multi-organ failure who are refractory to the standard medical management. And our center embarked on a retrospective study where we compared 76 patients who had endoscopic drainage, and along with 117 patients who had early intervention before 4 weeks, along with 117 patients who had the standard interventions where we waited for more than 4 weeks. And we showed that endoscopic intervention improved organ failure in both the groups, but it was more pronounced in the early intervention arm. And there was no difference between the immediate in the post-procedural complications, both in the early intervention arm as well as the standard intervention arm. The mortality, as you would expect in the early arm, was significantly higher, but it was 13%. And this we could attribute to the multi-organ failure. These are critically ill patients. This was also confirmed on another Mayo retrospective study involving 19 patients and by Dr. Rana's study at PGI as well. But then the Pointer study was published earlier this month, which looked at immediate drainage versus postponed drainage. And they concluded that there was no additional benefit in terms of for immediate drainage interventions. And in fact, the patients who had immediate interventions, immediate drainage, ended up needing more interventions as opposed to those who had postponed interventions. And in fact, 1/3 of the patients in the who were randomized to the postponed intervention group, completely, we could avoid procedures in 1/3 of the patients. So it's important to note the difference between our study and the Dutch pancreatitis study. Our study looked at defined early intervention as less than 4 weeks, as opposed to the Dutch pancreatitis group, which defined early interventions less than 35 days. And the median time for intervention was 24 days as opposed to 20 days in our study. And also, not surprisingly, the necrotic collections were walled off or largely or fully walled off in 60% of the Dutch pancreatitis group study, because the median interval was 24 days as opposed to only 40% in our study. And the organ failure they were dealing with was roughly was significantly lesser, and the organ failure in our group was 43%. And the endoscopic approach, which was done in half their patients, involved placement of plastic stents and placement of nasocystic drain, as opposed to our studies where we had used lumen opposing stents as well as other metal stents as well as plastic stents, and we were more aggressive with necrosectomies. Regardless, so the verdict here is there is a subset of patients who could potentially benefit with endoscopically centered early intervention approach. This subset is these are the critically ill patients with multi-organ failure who are deteriorating in the ICU. However, this should be performed only in the tertiary care centers with adequate backup and advanced expertise. The next question which comes up is which stents are better, the lumen opposing metal stents or the plastic stents? And there have been multiple retrospective studies which have addressed this, but one randomized control trial, again by the Varadarajalu's group, which showed that lumen opposing metal stents only resulted in a decreased procedural duration. In other words, it was 15 minutes versus 40 minutes. But there was no other significant difference in terms of plastic stents versus metal stents in terms of number of procedures or treatment success or complications. From our standpoint, if a patient is critically ill who is deteriorating, we would prefer the lumen opposing metal stent because it's technically a more quicker procedure. But in case somebody has predominantly liquid contents in the necrotic cavity, if they have disconnected pancreatic duct, or if a patient is going to be poorly compliant, the plastic stents are more preferred. And again, we need to factor in the cost as well. Lumen opposing metal stents in the United States cost more than $5,000. So if patients are paying out of pocket, the plastic stents should be preferred. Then the next question is just endoscopic transluminal drainage adequate? The answer is an emphatic no. We cannot place a lumen opposing metal stent and forget about these patients. These stents, we have to expect all sorts of complications after placement of stents. The Mayo Clinic did a study which looked at what are the predictors or risk factors for endoscopic necrosectomy or adjuvant pancreatic drainage, and they identified that necrotic collections greater than 10 centimeters, or patients who have paracolic extension, these are the ones who would end up needing necrosectomy or percutaneous drainage. So a few tips here to refine endoscopic drainage. Very often we come across long or collections which are pretty large, and these collections are best managed with a dual cysgastrostomy or a cysgastrostomy and a cysduodenostomy. This was studied, this is known as the multi-gateway technique, and was very has been studied by the Varadarajalu's group. And there are collections with deep retroperitoneal extension. These patients are best managed by combining endoscopic therapy as well as the percutaneous drainage. The percutaneous drainage should be placed retroperitoneally, and if they are not improving, then we need to do sinus tract endoscopy through the retroperitoneal drain. Then we have all sorts of necrolytic agents now, with hydrogen peroxide being the most popular. And again, hydrogen peroxide has been compared in a single center randomized control trial with streptokinase, where the hydrogen peroxide was associated with increased risk of bleeding complications. So it's not clear whether hydrogen peroxide can be used in all patients, but maybe in 1/3 of the patients. And we have other devices like the endorotor, which was popular for polypectomies, which we have used, and the VAN device, which appears to be promising. So finally, a word on complications. Risk of complications is about procedure-related complications, about 36% in endoscopic step-up approach, with 6% procedure-related mortality. And the most common complications is this stent occlusion and sepsis. And this is a very common site for therapeutic endoscopists. After placing a lumen-opposing metal stent, the liquid collection gets drained, and then the solids collection plugs the stent and causes infected collection. Bleeding is very common in patients who are on anticoagulation or who are on dialysis. It could happen during the tract dilation. We could sometimes use hemostatic clips, or we could use stents to tamponade them, but most often we need IR to perform angiography and perform embolization. Pseudo-aneurysms are also common in the setting of lumen-opposing metal stents. We performed a retrospective study where we identified 39 patients in our cohort to have pseudoaneurysms. In our study, the splenic artery and the gastroduodenal artery were the most common sites of pseudoaneurysms. But surprisingly, the choice of the initial cystentrostomy stents did not determine the incidence of PSA. It appeared that lumen-opposing metal stents patients had an earlier incidence of pseudoaneurysm. It's because the necrotic cavity gets rapidly drained, and then the distal flange of these stents impinge on the vascular structure along with the inflammatory milieu. This is why lumen-opposing metal stent is associated with earlier incidence of pseudoaneurysm. And the perforation, fortunately, is not common, but it could happen when the collections are not closely adherent. And fistulas to the colon and disconnected pancreatic duct syndrome are all other complications. This will be covered by Dr. Marty Freeman when he talks in the next session. Disconnected pancreatic duct syndrome, which are refractory to medical management, can be treated endoscopically with EUS pancreatic gastrostomy, but some of these patients need distal pancreatectomy with autoiler transplantation. To summarize, when we approach a patient with necrotizing pancreatitis, we need to optimize our medical management first. And then our choice of initial drainage depends on whether a patient has deep retroperitoneal extension. If a patient has a deep retroperitoneal extension, we usually do a combined endoscopic and percutaneous drainage. And if a patient does not have any deep extension, then we could manage them solely with endoscopic treatment. And if a patient has a collection which is far off from the stomach and the duodenum, we end up doing percutaneous drainage and followed by sinus tract endoscopy. And if everything fails, it's either VAD or open necrosectomy. And this is a team effort, and we meet as a group every Thursday to discuss the best choice for every patient. And nothing is possible without a team effort in management of necrotizing pancreatitis. Thank you.
Thank you, Dr. Trikudanathan. That was an excellent talk. We'll move on to the last lecture for this session. It will be by Dr. Nicholas Zaromsky, who's a professor of surgery at the Indiana University School of Medicine. And Dr. Zaromsky will be talking on surgical management of necrotizing pancreatitis. This will be a virtual session as well. And we're going to do a Q&A at the end of this lecture, so please save your questions for then.
Good afternoon. It's a privilege to share this podium with such an esteemed group of worldwide and world-famous pancreatologists. I've been tasked with bringing a surgical perspective to necrotizing pancreatitis and comment on the contemporary surgical management of this disease process. I have no disclosure. So what does surgery look like for necrotizing pancreatitis in 2021? Most patients, if not all, should be approached with a step-up approach with percutaneous drainage first for many. Surgery in this day is reserved primarily for the failure of step-up. A second group of patients who have appropriate anatomy and biliary pancreatitis should be approached by surgical transgastric necrosectomy. And a question is remaining whether surgery first approach should be highlighted for a patient with multiple field necrosis. Finally, if there's any concern for ischemic viscera, such as colon or gallbladder during the course of the disease, operative exploration is warranted. So this afternoon, I'll talk to you about minimally invasive surgical approaches, videoscopic assisted retroperitoneal debridement and sinus tract necrosectomy, surgical transgastric necrosectomy, and open pancreatic debridement. The goals of intervention in any of these approaches remains the same: delay if possible, control infection, evacuate fluid, and importantly, all of the solid necrotic debris, drain pancreatic fistula, ideally internally, but also externally in appropriate circumstance, prevent recurrence of pancreatitis in the case of biliary pancreatitis, establish enteral access, and to accomplish these goals with the minimal physiologic disruption to the patient. That's where the minimally invasive part comes in for many. No patient is perfect when considering patient selection. One should think about the necrosis distribution, the percentage of solid necrosis. Is the parenchyma involved? What's the infectious status? What about the etiology? Biliary pancreatitis, in my mind, an appropriate anatomy should be approached with surgical transgastric necrosectomy as opposed to multiple endoscopic interventions followed by surgery for cholecystectomy. And finally, it's important to think about what the local expertise is. We are mostly fortunate in this audience to work in high volume centers with experienced endoscopists, experienced surgeons, experienced interventional radiologists, but this isn't the case in many community settings. And so based on the local expertise, I think it's far more important to have one doctor taking care of these patients over the long term than any one specific approach. Percutaneous approach is the first step in the step-up approach for many, but percutaneous drains don't work all the time. And when the percutaneous drains don't work, the question is, when do you step up? This is an unanswered question. This highlights work by one of our former IU medical students, Elliot Yee, looking at a concept of dynamic frailty and trying to objectify this metric. This is building on work that was done and published by the Los Angeles group in a different iteration a number of years ago. The approach for many is minimally invasive surgery, such as videoscopic associated retroperitoneal debridement. This is appropriate anatomy with necrosis confined to the retroperitoneum, tracking down one retrocolic gutter. This is the approach highlighted by Hjalmar van Zandvoort's one of his original papers, percutaneous drains guide the approach, which is then visualized by either some sort of endoscopic visualization, and you can see operative debridement is quite straightforward. How about transgastric necrosectomy? I'm going to spend a little more time on this approach. Surgical transgastric necrosectomy is one-stop shopping. We are able to accomplish a thorough debridement in one step. We can provide internal drainage durably and avoid what our South American colleagues call El Diablo, the small disconnected pancreatic tail, in most. It is worth noting that 15 to 20% of patients will have recurrent pseudocysts, left-sided pain, and acute pancreatitis, so long-term follow-up is important. We can accomplish cholecystectomy with intraoperative cholangiography and place enteral access, again, as needed. This is a patient with ideal morphology for transgastric approach. Necrosis is confined to the lesser sac. Perhaps the neck of the pancreas is out. This patient population is often walking wounded and not the in-hospital patients that you see. This may be approached laparoscopically. Intraoperative ultrasonography is important. Anterior gastrotomy is created. Posterior gastrotomy guided by IOUS. Thorough debridement is accomplished. You can see the camera being driven into the necrosis sac, and the remnant of the pancreas is visible in the middle picture, along with the splenic artery, a bit disconcerting the first time you see it. The anterior stomach is closed. You can see the volume of necrosis, and this can be accomplished again, either laparoscopically or as an open approach, even through a very small incision. This picture in the bottom left highlights the fact that we prefer a large cystogastrostomy. We feel it facilitates long-term drainage. This slide is to highlight the fact that left-sided or sinistral portal hypertension is present in most of these patients, and to be cautious as you're going through the gastric wall. We've reported surgical transgastric necrosectomy outcomes. This is a multi-center report with Calgary, Stanford, and Indiana University. And I've highlighted the fact that repeat intervention is necessary in 13%, oftentimes endoscopy to salvage a primary surgical approach. This editorial from Gastroenterology a few years ago, by names that you'll recognize from this podium on this meeting, highlights the fact that one-size intervention does not fit all. This is important when we consider transgastric approaches, endoscopy versus surgery. What is endoscopy? Is this pure endoscopy, transgastric approach, multiple gateway, the Virginia Mason, endoscopic plus percutaneous approach? Is it transpapillary? And what is surgery? Open, transgastric, laparoscopic, VARD, sinus tract necrosectomy, laparoscopy? I'll show you some data from Indiana University, a single high-volume center. This bulk of this work was done by Tom Mottman and Sean McGuire, the guys pictured here to the right. We looked at our necrosis experience between 2008 and 2019, 771 patients, most of whom required intervention, 160 of whom had transgastric debridement. So this is a 30% of this pancreatitis population were suitable for transgastric debridement, mostly operative and endoscopic. The operative and endoscopic groups were matched in demographics. They were matched in clinical course, specifically with CTSI, volume of necrosis, organ failure, etc. The outcomes, not surprisingly, were different. And again, this is a descriptive study. We put statistics on this, but the idea isn't necessarily to compare apples to oranges, but to show differences among the groups. Again, not surprisingly, there were a greater number of interventions per patient in the endoscopic group. There were a greater number of readmissions. This is unplanned readmission in the endoscopic group, and the length of stay was similar. So we concluded from these data that operative and endoscopic transgastric debridement both achieve necrosis resolution with different temporal and procedural profiles. It's clear in my mind anyway that multidisciplinary communication is essential to determine the appropriate approach to individual necrosis patients. These data, again, have been published in the Annals of Surgery this year. So what about the final word of endoscopy versus surgery with transgastric debridement? I think that surgical and endoscopic debridement are just two of several often complementary approaches to treating necrotizing pancreatitis, and that we really have to get beyond comparing one technique to another, mine is better than yours, and focus on defining more objectively which patient warrants which approach, when is the best time to step up the therapy. And finally, long-term data are critically needed to evaluate some of these techniques. I'll conclude with a few words about open pancreatic necrosectomy. What about the advantages? Well, we can achieve multiple necrosis debridement with a single procedure. We can achieve cholecystectomy therapy for biliary pancreatitis. We can deal with a small tail remnant by distal pancreatectomy in a stable patient. This is time-tested and safe in the hands of a capable general surgeon. And this is the historical standard. We're not going to have comparison of open necrosectomy to endoscopy to perc drain. It's not necessary, but it's important to keep this in mind and apply this in appropriate circumstances. I was asked a few years ago to speak at the IHPBA about open necrosectomy, and so I gathered my own personal experience with 116 patients. You can see the majority of these were open debridement, some transgastric, laparoscopic, VARD. Many of them had other organ resection, tail of pancreas, colon, etc. You can see the operative statistics and the mortality. And again, this is a highly select group of patients from a single surgeon with a great deal of experience. We've published these paper in Pancreatology a few years ago. And this conclusion, this is my personal bias, again, based on significant interest and experience with the problem, is that surgical necrosectomy is one tool. When it's applied appropriately, it can provide safe and definitive therapy and facilitate rapid recuperation. The challenge is the judgment to see which patient is appropriate for open necrosectomy and what about timing. So my final thoughts about necrotizing pancreatitis is this is clearly a heterogeneous disease, and clearly one therapy does not fit all patients. Many, if not most, will benefit from multiple approaches. Consistent care is necessary for long-term illness. Patients can reach a point of physiologic exhaustion, so we can't wait too long to intervene. And once intervention is initiated, the clock is ticking because necrosis is a catabolic problem. This is clearly a multidisciplinary approach. I highlight this with my friend and colleague, Dr. Evan Fogel, expert endoscopist here. We're probably discussing either necrotizing pancreatitis or which sporting event we should attend next. I'll leave you with this slide. This is a slide that I've put in every pancreatitis talk I've given for over 20 years. And it's a little demoralizing to see that I just changed the date. In 2021, no specific therapy exists for necrotizing pancreatitis. We're treating the complications of the disease. We need more hard work to focus on figuring out the physiology and appropriate treatment for the disease. Thank you again. It's a real privilege to speak to this group. I look forward very much to interacting with everyone in person in the near future.
Thank you for this excellent talk, and actually thank you for all excellent talks. And so the session is open for questions, and Guru, please join us up here. Looking for the microphone, Aliyah.
Thank you for the excellent talks. It's really thought-provoking about the management of patients with necrotizing pancreatitis, and since there's no specific treatment. And as I was listening to the talks, you know, how do you and when do you involve your surgeon? Since, you know, you may never have any interventions, you may have, you know, depending on the center's expertise, you may need to do percutaneous treatment, you may need to do endoscopic treatment, or you may, your patients may be different and you may need your surgeon's expertise. And this may also depend on the center. So when do you involve your surgeon if you have a patient with necrotizing pancreatitis?
Yeah.
So I think this is open for everybody.
Yeah, I was just about to say that's a great question because we have therapeutic endoscopists and surgeons. So it's a great panel to ask this question to.
Yeah. So who wants to go first?
I go first. As a group, we have our surgeons available as a backup. We are an endoscopically strong group, but we have our surgeons available as backup. Only 6 to 7% of our patients had ended up needing an open necrosectomy, but they are involved in all the decisions. And as you probably know, some of the critically ill patients may develop abdominal compartment syndrome and who may need open fasciotomy by surgeons. But we involve, everything is done multidisciplinary in our system. We have we involve our interventional radiologists more than our surgeons. But they see the patients as soon as a new necrotizing pancreatitis comes and they're available for backup.
Right, thank you.
Yeah. If I may, can you hear me in the audience?
Yes, very well.
Hi, everyone. Sorry I'm not there. I see some familiar faces there on the first row of the meeting. I'd love to be there next time. So I think the key point is typically we talk to each other too late, right? So the endoscopist will show a scan and say, listen, I did 12 necrosectomies. Patient has been in hospital for 3 weeks. Can you guys do something? And then you typically would say, well, if we had this discussion 3 weeks earlier, paracolic gutters, both paracolic gutters, etc. We have a pancreatitis meeting every Tuesday morning at 8 o'clock. But the challenge is, of course, if you are a doctor and you think you can solve the problem, to then go first speak to another doctor, whereas you think you can do it yourself. And I completely understand. But I think all of us should try to get the message across that we need each other, and together we can do a better job than on our own. Like actually everyone in this session has said. So I would like to stress that point.
All right, thank you. I think Dr. Zamorsky was raising his hand.
I have exactly the same feelings as Mark. I'm a surgeon, so I'm involved. You know, when I get involved, we are really fortunate at IU. We have a huge volume like Minnesota, like Amsterdam, like PGI. And the message from this group is beautiful because it's consistent. And this is a multidisciplinary disease problem. Surgery is not better than endoscopy. It's not better than percutaneous drainage. Each one of these interventions has a role. And the trick is to try to figure out what suits each patient best at what point of time in their disease course. And then this may be an extension of a question, you know, for Surinder or Marty or Guru. How do you figure out what's the best time to step up? You know, we're working on trying to get objective metrics, but you can't just put an Axios in and let the guy go home for a month because he'll come back septic in 2 weeks. Once you put perc drain in, the clock is ticking. You know, Mark and Yalmar highlighted this in the Panther trial. You need early repeat CT scans, early repeat interventions if you're not making progress. But my answer to the direct question is surgeons should be involved early, GI should be involved early, interventional radiology should be involved early. Whoever the physician is who's driving the therapy, the captain of the ship, doesn't matter who it is, as long as somebody sticks with the patient for the long term, but makes sure everybody's talking to one another.
All right, thank you very much. That's the point that I was trying to get across. It's a multidisciplinary work, and we all have to work together. Thank you.
Thank you. It was an excellent session, and I was going to allude to the point that Aliyah had made earlier, and maybe just reflect a little bit about the experience of multidisciplinary management. I think the take-home points is that you need everybody in the room. We have weekly radiology-run pancreas meetings where the radiologist and interventional radiology are both involved, advanced endoscopy, the surgeons are in the group discussion, and medical pancreatologists. So it's really not who is mainly managing the patient, but having the discussion early on and together. And the same patient could be a moving target, so the picture changes. So you have weekly meetings and everybody's on the table, but there has to be ad hoc discussions because what you predicted is going to happen doesn't happen, or it becomes infected, or the picture changes. What I've seen as a pediatric center is mismanagement and people doing surgeries or interventions on patients not really indicated, where we as a centralized, for instance, discussion happens too late, and that only affects the patients for bad outcomes.
Yeah, thanks a lot, Maisam, for that comment. And it's fairly obvious to all of us who manage these complex necrotizing pancreatitis patients that it's not a one-person job, and it's not a quick and easy turnaround in most of these patients. One of the questions as I was listening to the talks is we'll often, even at Mayo being a tertiary referral center, we'll have patients sent to us after they've had a percutaneous drain placed at a center that maybe did not have access to endoscopic intervention. What is the, and I'd like to hear from the speakers, what should be the approach in that setting? Do you, obviously they're being transferred, which means they're not doing really well. Do you decide then to switch over to endoscopic intervention? And if you do that, what do you do to the percutaneous drains? Do you leave them in? Should we leave them in? Do they need to come out sooner than later? I think the audience would like to hear your thoughts on that.
Good.
Yeah,
So,
nobody in particular, please.
So I can go first. Mark Besselink here, Amsterdam. So as a surgeon, if there's already percutaneous drain in place, so someone decided to start with the surgical step-up approach, we would upsize the surgical drain to a really appropriate drain, so that chest tube size drain. And if the patient doesn't improve with that, after 2 drainage procedures, do a VART procedure. If it's a tiny pigtail and you think the patient is appropriate for EUS, I guess just placing an additional hot axial stent or plastic stent transgastric would be the way forward to prevent the patient getting a percutaneous fistula.
I think that each one of these patients needs to be managed on an individual basis. You know, we see this also all the time. I'm sure all of us see this. There's one very small drain in a large volume of necrosis, but what's the morphology of the necrosis? Is it down 2 paracolic gutters? Is it mostly in the retrogastric space? Is the head involved? Is the SMV out? Is, you know, where is the patient in the course? Is it 2 weeks in? Is it 8 weeks in? What do they look like nutritionally? Is it biliary pancreatitis? You know, all of these things play a role. So yeah, I think once percutaneous drainage has been started, definitely going down that pathway, upsizing additional drains. Surinder was very lucid about how, I mean, that's world-class management, right? You know, described for you in a 15-minute overview. But then the trick is to see, when is it stalling? Are you accomplishing evacuating the solid necrosis, or have you stalled out? And then do you need to go to a VART, or do you need to go to sinus tract necrosectomy or percutaneous dual modality type drainage? So I think it really depends on the individual situation.
Surinder, you want to add to that, either you or Guru?
Yeah, I think I just agree to what other points have been said. There is no single formula which will fit for any particular patient. It has to be interdisciplinary. We have to talk to surgeon and IR people. And then we have to look at the morphology and the clinical profile of the patient before deciding on to the next step. But I think the critical question which is still unanswered is an objective criteria to determine when to proceed to the next step. So till the time we have an objective criteria, I think the best solution is an interdisciplinary consultation with your surgeon and IR to decide about the next course of action if your patient is not improving.
There's a question on the panel. Marty Freeman is on the panel and has a question regarding timing of intervention related to clinical course. Should clinical deterioration or new onset organ failure lead to intervention early? And Mark, I think you had a comment or an answer for that.
Yeah. If the chairpersons allow me to do so.
Sorry to hijack the chair. Yeah.
Please.
Thank you. No, I thought Guru had a beautiful presentation, and I think Guru tried to make the point that the Dutch pointed trial in New England that early was not so early. And although I appreciate your comment, early was very early. Early in the pointed trial was within 24 hours. So what does that mean? That means that all patients with pancreatitis nationwide were followed by the study team, and anyone who had then had any signs of infection, as per the definitions in the protocol, so either gas, positive FNA, or after the first 14 days, clear clinical deterioration. So the clinical team made the diagnosis of affected necrotizing pancreatitis. Then immediately they were randomized, and if they were randomized too early, they had an intervention within 24 hours. So honestly, I don't think that could have been done any earlier. So the strange point is, and listen, we were trying to show that earlier was better as well. I mean, we were enthusiased by your results, Guru. But in fact, it is. I don't think it is. The study didn't show that mortality is worse or complications are worse if you drain earlier. But to our surprise, 40%, 40, only need antibiotics. And they don't even need a drain. And they go home 2 weeks earlier. So I wasn't expecting that. So I think the mistake which is often made is that your patient is sick and has a collection. But the collection is not the cause of the patient being sick. The patient is sick because of necrotizing pancreatitis and SIRS and organ failure related to inflammation. So although many of us are interventionalists and we want to do something, and I also want to do something, but I think they are sick and have a collection. And mostly in the early days, they're not sick because of the collection. They're just sick and there happens to be a collection.
Thank you. That was a great overview of some of the challenges that we face in managing these patients. I know we don't have a lot of time left in the session. Disconnected pancreatic duct is another one of those challenging situations, and maybe I can hear from either you, Guru, or Surinder, how that influences your endoscopic management plan up front.
So in patients with disconnected pancreatic duct, on the initial CT, these are the patients who have pancreatic necrosis, who have disconnected pancreatic duct. We try to leave the transmural stents indefinitely. So in other words, we try to leave the plastic transmural stents indefinitely. So one approach is to start off with plastic stents and keep working with plastic stents. Another approach is to do the lumen-opposing metal stents, but change them to plastic stents right away so that you could have those transmural stents. But I'm sure Dr. Freeman is going to discuss later that we also come across patients who have obstructive pancreatitis of the upstream parenchyma despite having transmural stents. And these are the patients we really struggle with. And some of these patients, they end up needing EUS-guided pancreatic or gastrostomy, or some of them end up needing distal pancreatectomy with islet autotransplantation.
Any other comments from our panelists?
Yeah, can I make a comment on this?
Sure.
So I think an important thing to understand is that probably we are learning that disconnected duct is not as bad as we were initially believing it, because we used to leave stents in all the patients, but gradually we are realizing that many of these patients actually don't develop any symptoms even if we haven't left the stents. So we probably need to identify those patients who actually need the transmural stents to be left indefinitely. And I think it's an ongoing work. Probably we'll be able to identify the factors which will determine that which patients will develop a recurrent pancreatitis of the remnant pancreas and the ones who will remain asymptomatic.
Thank you. So that was excellent discussion, and I have to close the session because we're moving on. Again, thanks for all the Zoom callers and the on-site, representative. And I ask Fred and Fear to come up and continue with the next session.
Thank you all.
Thank you.
Thank you.
chair.
Yeah, let's have questions.